Hello and welcome to the NewsX Sunday Guardian Roundtable. Well, India has reported as many as 137 cases and counting of coronavirus. There have been 3 deaths also. Well, the problem is very serious. We've had an ICMR briefing that's told us that India is in stage 2, stage 3. How far away is that? How do we deal with the situation? There's been a lot of information overload on coronavirus. Every show talks about it. Here on this show, we're going to be doing 2 things. We're going to try and separate, try and give you the facts, try and break some of the myths that are doing the rounds. And secondly, what do we do next? What is the road ahead? How are we dealing with it well? Is our reaction correct, or are we overreacting? Do we need to panic more? Those are some of the questions that I will be answering. Joining me on is a panel of experts. I have Shailaja Chandra. She's been a secretary in the Ministry of Health and also chief secretary in the Delhi government. We have Dr. Virendra Chauhan. He's an ex-director at the International Center for Genetic Engineering and Biotech, and he continues to be an emeritus scientist over there. He's focusing on infectious diseases. We have Dr. Swati Maheshwari. She's also an expert on internal medicines, and she's a former senior consultant at the Fortis Hospital. And Dr. Anjali Katra, she's a disaster management expert. She's the DG at Disaster Safety Center. Ma'am, I'll begin with you first. Our response, how do you see India's response to coronavirus? Are we panicking, or should we be more stringent in some of our measures?
I think India has done what needed to be done well in time. So I would give full marks to the way they contained the arrival of the foreign visitors and Indians coming from countries which have had this outbreak. They started the checking on the bridge of the airplane and through the manifesto identifying the passengers in front and passengers behind the suspect case. They started the kind of follow-up through the Integrated Disease Surveillance Project, which is an all-India project so that you're able to identify and clustering. That was all wonderful. And I think that India could really teach a lesson to other countries how this was done. It was really commendable. But we are now, as you said, getting in from phase 2 into phase 3. This is the phase when central government orders, which emanate from WHO Geneva and which are being followed, will no longer be the benchmark. It has to be a local reaction, a local response. So every state government, every chief minister, every chief secretary, every district magistrate, every CMHO, that is the medical officer at the district level, percolating down has to be on the same wavelength. You can't have a knee-jerk reaction, humne ye kiya, usne kya kiya. There's no harm in having a state policy because this is something which only a state chief minister can order. If he takes interest, definitely things fall into place. This is something which in our system works. But it requires a chief minister to put everything aside and give this the primacy it deserves, because it really means looking into whether you have testing equipment, whether you have roped in the private sector. I've heard that now they're opening it up.
The testing labs.
Testing labs. Now, which ones are you going to consider to be all right? How are you going to link the population with that center? People can't go helter-skelter throughout the city or throughout the district. So therefore, you can use election data, for instance. You know the populations, you know the licensed laboratories, and link up people. Are you going to insist on prescriptions, or are you going to insist on anybody having a cough and cold landing up? These are questions which immediately the state has to take charge of. And as I keep saying, we are really administering populations of Italy, France and Germany. When you talk of Rajasthan and Tamil Nadu, which is the size of France, and Germany, which is the size of Bihar. So
and you're not even going to Uttar Pradesh.
Uttar Pradesh is the size of Brazil. Okay. So, so when you have this kind of a phenomena, what do you need? If really it has reached an emergency level, you have the containment of people coming from outside, even Indian passport holders, which is a good thing. But if that person has gone into the community, he's gone to Bangalore, and the woman has gone to Agra, which we have seen happening, how do you nab them and all the people, the ripples of people around them who have come into contact with this person? Now, there I would say that the state has the machinery. They've been doing it for polio, they've been doing it for HIV/AIDS, they've been doing it for malaria. this is different. This is a virus which is not mosquito borne. It is borne by just transmission through the air. So there it is possible to have a system whereby any compact area, any high density area, you have randomized sampling done just to know what is happening in that community. That is necessary.
Okay.
When you talk about, for instance, the district magistrates and the CMHOs, these are and the municipal commissioners, these are the three key players at the Indian level who can make things happen, and you need your best officers put here.
Okay.
Because they must be efficient and they must be result oriented. They can't say कि मेरे पास ये नहीं आया, वो letter नहीं आया, वो चिट्ठी नहीं आई. It has
no
to be
time
hands
for
on.
the-
I think very fantastic point that ma'am has made, because at present also right now we have a lot of states who have still not imposed this lockdown. We still have states in India and we still are allowing interstate movement. So there's so much of interstate movement happening, yet some states are locked down and some states are still not locked down. I think we are on a very...
policy has not yet come that, you know, we've of course had quarantine centers. We are, you know, we've also said, given a list of people who need to be quarantined, who are showing symptoms or who just travel from abroad and come. So are you happy with this response, or you think it needs to be further streamlined?
I think it will have to be further streamlined, because it's like, you know, in the old days you had cholera. It's an infectious disease under the Municipal Act. And it is the duty of the municipal commissioner to see that there are isolation facilities. Now, here, is it going to be a top-down approach? Is the municipal corporation going to do this? I saw some tweets from municipal commissioners saying, "Ye kaam hamara nahi hai. This is being handled by health." This is something which is very problematic. I think you need a protocol down to every district. Who is in charge of identifying isolation and quarantine centers? What is the quality of those supposed to be? Are they paid or they are unpaid? If they are unpaid, then government has to have a modicum of standard. If it is paid, then you have to have modicum of standard and tell people you pay and go there if you don't want to be in a government facility. That is the first. Second thing I think is that when you start opening it to private sector, to do the testing, because you will have to go to the private sector. There's no way government can do it. And private sector has enough facilities. But today the time taken, Dr. Chauhan will definitely say it takes 32 hours or something. Maybe it takes more, maybe it takes a little less. But that's a very long time. By that time, are you going to keep him in isolation or are you going to send him home? So therefore, the question arises that if you are able to reduce the testing time, there are people going around saying it is possible to reduce the testing time. We need people of eminence who have the last word on the subject. This is fine. Take it on. I don't know who's doing that. And the third thing is about the states. I mean, one would expect that there would be a kind of a protocol for every state without fail to follow. It's not, yes, I agree totally with Professor Chauhan. The operational part can be left to the district magistrates to do whatever innovations they want to, whatever the public health machinery wants to, but there has to be a straight protocol. How will you report? How often will you report prevalence and incidence data? If you don't have prevalence and incidence data, you cannot forecast. So you need that. In plague, we used to do it. We had no email in those days. By fax, the messages used to come by 5 o'clock saying how many new cases, how many new deaths. And it was possible to say, to forecast. Of course, it was much simpler. You had antibiotics, sure shot, you might say, treatment, and you could contain it. I'm not drawing a parallel. This is hugely serious. I'm not deprecating efforts, but I'm only saying that unless the last man at the level of a tehsildar knows what is to be done, it will not fall into place just through awareness. There has to be a protocol for how will you identify, how will you send for testing. At the, you might say, look at India. I'll just take a minute. India is 67% still rural. 640,000 villages are your, you know, your constituency. You have only 37% in the urban areas. Now, are you going to treat the urban areas as only Delhi, Mumbai, Lucknow? No, you will have to go down to the class 2 and the class 3 cities.
So
now,
which is where you
there,
need the DM and the
You
tehsildar.
need the DM, you need the municipal commissioner. They must all be talking exactly the same language. Then only it will...
That's it from now. Thank you for watching this show. We'll see you again same time next week.